Welcome, everyone. I am very excited and thrilled and glad, pretty much ecstatic, to be able to introduce you all today to Dr. Tish MacDonald Wer and Dr. Adriana Macias Strutt. So I'm going to introduce a little bit about both of our presenters before handing it over to them for a fantastic talk today. So Dr. Tish MacDonald Wer is coming home to New Mexico to us virtually. Currently, she is a leader of inclusive excellence and a clinical neuropsychologist in the section of psychology at Texas Children's Hospital. She's also an assistant professor in the Department of Pediatrics at Baylor College of Medicine. She received her Ph.D. in clinical psychology from the University of Denver, with specialties in neuropsychology, cross-cultural awareness, and statistics. Dr. MacDonald Wer completed her internship and postdoctoral training in clinical neuropsychology here at UNM, and she stayed on as faculty as well. During her time at UNM, she founded the Multicultural Excellence in Neuropsychology Training and Evaluation, MENTE program, which is a center that's dedicated to providing clinical training, research, and service delivery to linguistic minorities. At Texas Children's Hospital, she's currently developing and implementing an inclusive excellence program in the section of psychology. She serves in her free time on several national and regional boards and initiatives that are focused on increasing healthcare equity, fostering mentorship, and strengthening the student pipeline. And for Dr. Adriana Macias Strutt, is a board certified clinical neuropsychologist, associate professor of neurology and psychiatry and behavioral sciences. She's the founding director of the BCM Cerebro Spanish Outpatient Clinic, the Spanish Cross-Cultural Fellowship, and Taquitos de Sesos, an international online didactic program at Baylor College of Medicine in Houston. She's trained as a lifespan clinician, and she currently works primarily with adults, conducting forensic work as a clinical researcher and also an international educator. So we welcome you as well, Dr. Strutt, to our UNM family today. And with that, I will pass it on to you all.
Thank you.
Thank you so much for the kind introduction, Dr. Smart. And Dr. Smart and I actually go way back from UNM, from the University of Denver. She was the first person that I had lunch with when I was interviewing for University of Denver for graduate school. And then we ended up serendipitously in the same location. So thank you so much. And it is truly an honor to be able to present today. And we are excited to share our SALUD Strutt MacDonald and Equitable healthcare model as a framework to foster good trouble and make programmatic changes in the delivery of care, training, research. It is great to be back at UNM virtually. I miss it incredibly. As Dr. Marks shared, I completed my training and began my professional career at UNM. And so much of the work that we will be presenting today was inspired, motivated, championed, created with the UNM community. And I see a lot of familiar faces and names. So they at salud.unm.edu. And we were trying to come up with a name. SALUD stood out as it means health. Can you hear me? I'm hearing my connection being unstable. Okay, great. It means health in English, and it was broad enough to be implemented not only in neuropsychology, which is our area of specialty, but in other healthcare areas. So thank you for having us today. Next slide, please. We have no disclosures to report. And really, in putting together this presentation and giving our talk, we want to explain our motivation for developing this model. Our objectives are to give you an introduction to our model by highlighting how it has been applied to different organizations, and in closing, share our achieved accomplishments, our lessons learned, which have been many, with the hope that this presentation encourages you to use it as a blueprint as we work toward the reduction in health disparities and increasing healthcare equity in the United States and internationally. So let's get started and talk about the landscape, which New Mexico has a beautiful landscape. And we have practiced neuropsychology and continue to do so in unique states where the predicted demographic change in the United States is previewed. And as you all are well familiar, in New Mexico, we serve a high proportion of individuals and families culturally and linguistically diverse backgrounds. And throughout our careers with Dr. Strutt, it became strikingly apparent that we needed to consider all aspects of our work, including education, training, and research. And it was not just clinical that was important. Next slide. So we needed to take action. And that is how Dr. Strutt and I met. It was planning a conference for cultural neuropsychology. And we both agreed that we were tired of going to conferences where it was shared that cultural neuropsychology or cultural linguistics, yes, it's hard, we don't have the tools, and leaving it at that. We really wanted to showcase the action being done, not just the theory. So in our many attempts to address the experience disparities and increase equity across the mission areas of our organizations, we realized we needed a blueprint that really highlighted the action, something tangible that would function as a guide. So we started to operationalize our day-to-day. We were already doing it. So thinking about how we wanted to advocate for our program as a whole, the patients, our colleagues, our learners, and we also wanted to have the opportunity to showcase our accomplishments and what had already been done and what we were doing in our day-to-day practice. So we will share about our process and how the SALUD model came about. So Dr. Strutt and I engaged in many meetings and telephone conversations and shared our experiences in each organization and with our training as well. And we sought feedback from our colleagues who were familiar with our work. Some of you are on the line and connected today, and really thinking about creating a model with the focus of cultural neuropsychology. Our list included our daily to-do list. We were like comparing what we were doing, our ongoing projects, our pipe dream initiatives that we wanted to accomplish, our stakeholders and our champions that supported the work that we were doing. So really it was a tremendous partnership and collaboration.
Sorry, I'm having to manage the slides and the Zoom on two different screens, and it's throwing me off a little bit. So we'll start a little bit with our theoretical framework. As Tish said, these are all things that folks who are involved in cultural neuropsychology are well aware of. And so some of the slides that we'll present next are more for future readings for you or for the trainees to have as a reference. But we obtain guidance from our interactions with our colleagues, both nationally and internationally, and took to the literature to identify basic standards across our identified missions with the goal of rooting this model into a theoretical framework. These are some of the models that we investigated. We looked outside of the field of neuropsychology. We wanted to obtain a basic understanding of the view of other healthcare providers in different fields, so that we could identify the strengths of some of these models, but then also become aware of aspects that were missing that we might be able to incorporate into our own model. So the reviewed literature supported our clinical experience, which was a wonderful feeling to have after so many years of hard work. And it guided our vision in creating our model. In this process, we reflected on the decades of research and the urgent need for a blueprint that would support immediate action. As Tish mentioned, that was our goal, was to sort of, get boots on the ground and get started with what we wanted to do. And so with our model, it allowed us to work in these different areas simultaneously, so that we could address the different needs of the patients and the learners that we were working with. And while gaining knowledge and skill, we created and gathered resources and engaged our stakeholders and our champions. And we formally began the dynamic process toward continuous individual and programmatic growth. I say formal because I had been doing this already for about 10 years. But I had no way to highlight the work that had been done, the gains that we had made in clinic, and the process and hard work that is needed to train the student pipeline in this type of work. And so this was more of also allowing us to document the steps that were needed in order to create this entity that we had already started many years ago, but could finally put down on paper. So I introduce you to the SALUD Strutt MacDonald Equitable Healthcare Model. This was a labor of love that Tish and I created with the support of our colleagues, our learners at different levels. I think a bird's eye view can be quite overwhelming. There are 8 components, and then part of those components have many elements. Some of these I think overlap, and depending on how you view them, you might find yourself doing work that maybe is labeled under education and training, but the deliverable comes from a QI perspective or a consultation and collaboration. The goal of our talk today is to try to piece this model apart in very limited time, but to give you a basic understanding of how we have used this and the gains that we have made. So also to highlight all the work that is needed in our future plans. So our intention is not to overwhelm you. There is a QR code that you can utilize that will take you to the Baylor website, where we have references and detailed descriptions of each of these components to help you work toward using the model in your own program. So we hope that you can appreciate the value of implementing this model as we walk you through it and explain to you how we've used it in our institutions. And then at the end, we hope to have plenty of time to hear back how you might be able to provide feedback to us and then future guidance as to how we can continue to develop this work together. So we are in Houston. I'm sorry that I took Tish from New Mexico, but I am so glad that she is my neighbor down the street. We hope you can, sort of think of Houston and Texas. We are the most diverse city in the nation, and we take care of a lot of non-English and non-Spanish speakers as well. So this was just a nice slide that we put together to give you an idea of the most prominent cultures and languages that share our community. Oh, you're muted, Tish.
Thank you. So to start, the model was first utilized at BCM in the Cerebral Clinic and at UNM in the MENTE program at the Center for Neuropsychological Services. And these were our academic locations when we finalized our model. We were implementing now at Texas Children's the Inclusive Excellence programming in the psychology section. And then in 2018, it was implemented by Dr. McCauley at the Baylor Echoes program in clinic. So we have, 3 organizations and 4 different programs. And as we're going through, you'll see that we're highlighting parts of each of the missions. So we'll highlight something that from the Baylor College of Medicine and something from Texas Children's. And there'll be much other projects we're not gonna address because there are too many. But we really want you to think about your program and what elements and components of the model you've already put in place, because as Adriana shared, a lot of the work we're already being done, and it's how we formalize it and really highlight it. So think about that as we're going through. And the first thing that we start off is a needs assessment. As you saw from the model, it is dynamic in nature. And the first step is really to identify stakeholders and what we love to call disruptors that engage in good trouble. Find your allies and talk to them. But at the same time, respectfully provide a space and engage in conversations with individuals who may have doubts and are fearful of changing the community. That is very necessary to make it sustainable. Both perspectives are equally valuable. In tandem, another step is a needs assessment in order to identify inefficient and effective processes in a systematic way. The combination of both conversations and formal needs assessment is based on the framework of community-based participatory research and we see each organization as their own community. Dr. Strutt and I are researchers at heart, so we recommend presenting the findings of the needs assessment to your community, the entire community. This allows you to gauge the level of participation, promote buy-in from the community and the stakeholders. The community needs to feel represented to take ownership, and one person can't do it all, and we'll be sharing that as well. So our experience has really truly shown that this approach leads to greater level of engagement when you take a needs assessment perspective.
So my needs assessment at Baylor was less formal than Dr. MacDonald's over at TCH. And part of that is because I was a one-woman show for many years and had practicum student and fellows, but that were not necessarily my own. They were rotating. They would come and share some, a couple of months with me in the Spanish clinic. And it wasn't until almost 10 years later that the fellowship became a member of the APPCN program, that it was a formalized opening and training program, and that we were able to get that documented. So, it was a long time coming. It didn't mean that we didn't have the services before, and we'll talk a little bit about this later in development, but it was, the needs assessment was more about the discussion and a less formal survey with the students about their experience prior to starting here at Baylor, then their time in clinic, what they had learned, where they felt that the program was lacking, and how we could increase both services to the patients and to the trainees to help us provide a higher level of quality service.
For me, I was coming into Texas Children's to a new community. I had been at UNM as an intern, as a fellow, and then as faculty. So I knew the community well, and here it was different. So our needs assessment started at the end of 2019, and we had all the members of the psychology section community complete a survey. And our questions that are listed there were from a culturally responsive and equitable care framework to determine our starting point and really guide our strategic plan for 2020. And we presented the findings at our first quarterly meeting of 2020, and then the pandemic hit. So a lot of the work has been done, virtually and through pandemic. And we really needed to know what improvements needed to happen to then document and reassess at 2021. So we did that at the beginning of this year, and numbers speak and they keep the systems going, and thankfully we have learners and faculty that are vocal. So this has led to 2 quality improvement projects, one in improving training and education of our faculty, as well as one of providing recommendations in Spanish for our families and other languages. So we'll talk about that in the quality improvement projects.
The clinical services were pretty much implemented prior to the model coming into play. And so what we were able to do was utilize our clinical experience to help mold some of the elements of this model. We were training our trainees to understand that there are limited resources, but we don't want to use that as an excuse. We want to see how we can utilize what we have to our advantage and to better service our patients. And so understanding, the limited base rates and medical comorbidities, the impact of how some of those conditions are different in our ethnic diverse communities, and how folks are treated or might not be able to access treatment because of sociodemographic challenges. All of those things were already incorporated into our clinical service model. And we were able to use that by creating core batteries and supplemental material, ensuring that we had accompanying normative data so that we could then train our folks to be able to interpret our diagnostic impressions via a cultural lens, not just doing language and culture in general terms, but understanding the sociodemographics of the patient and really tailoring the assessment and the recommendations for the individuals that we were serving. So we'll do a little bit of comparison between the services at Cerebro and then at TCH. We also were able to expand our services here at Baylor. Cerebro started in 2017 formally, and then we were able to include ECHOS, and the ECHOS clinic services non-English and non-Spanish speakers. We currently have about 15 core batteries that we're able to work with interpreters to assess these communities. Now, not all batteries are complete comprehensive batteries. It's taken us a couple of years and we're still not there. But with the work of collaborations between international and national neuropsychologists, with cultural brokers, psychometrists, even folks in the field of neuroscience, we have been able to try to at least come up with something that we can use while we, of course, consider the validity of these measures and the practice of what we're doing. We're trying to be as culturally sensitive to the needs of the patient, understanding the limitations of the tools. But at least it has allowed us to expand our program in that sense. And that's been a very nice service to have.
And then the clinical integration and application, it's, not the knowledge base, but really the skill integration application, day-to-day services, right? And these really start from when the family calls and asks for an appointment, right? Who are they being greeted? What languages are the forms being completed? All the way to documentation and what is shared with the family, how is it communicated with all other providers? So really thinking about our system, our processes, the leadership, and the day-to-day practices, and where that might there be pitfalls or things that we need to improve to create that access to care for everybody.
Here, the gain has been a long time coming, but what we've been able to create are tailored recommendations in Spanish for our Spanish-speaking adults and older adults. And so when feedbacks are not available through the neuropsychology section, the referring provider is able to, take that neuropsych report and maybe cut it in half. And the first half is in English for the provider to go over all of the neuropsych jargon and the findings and cognitive domains with a diagnosis. And the second portion of that report is something that the patient can take home in Spanish with tailored recommendations on the things that we are recommending based on their neurocognitive profile.
And then the example that I want to highlight for TCH is one, true and dear and near to all of our hearts as we, telemedicine was being done at UNM before the pandemic hit. That's where I learned telemedicine. And, when the pandemic hit, we were building a plane while flying it, right? And trying to figure out competencies, as clinical providers, resources. And what it became very apparent is a lot of our linguistically diverse families were getting instructions in English, a new technology, and nothing was taking that into account. So from the psychology perspective, we went to the literature, we came up with really like an application of skill-based. These are the things you need to consider. These are the things you need to think about when working with culturally and linguistically diverse families in telemedicine. That then became a partnership with our eHealth services for the hospital. And they shared it for the whole hospital of like, okay, providers, we need to keep all these things in mind. We brought all the instructions in Spanish. We had a troubleshoot wizard, all these things. Now we're doing focus groups to talk about the experience and improvement, again, going to that quality improvement. And then it was shared nationally with clinical psychology as well as neuropsychology. So it really highlights the ripple effect of, a small practice trying to improve services and being that voice and then going through the organization and nationally. So really a true integration and action of what can be done when we're thinking about these things in new novel approaches as the healthcare field continues to evolve.
So for our education and training component, the focus has always been on patient-provider interaction using a evidence-based curriculum. But here there's an embedded supervision model. that is the culturally expressive and responsive model of supervision, which is bidirectional, and I think something that is truly needed in the field of cultural neuropsychology. So in addition to the model, we also wanted to use a model to highlight a safe space that is needed for the students and supervisors to interact and have difficult discussions that will address issues such as minority tax, identity development, not just for the trainee, but also the development of the supervisor and how that has evolved throughout their career, to discuss cultural humility, and then the many hats that both faculty and trainees will be wearing throughout their training and throughout their career, with being advocates and having knowledge and creating, ensuring that you have the highest level of skill acquisition when you're working with culturally and linguistically diverse patients. So part of the education and training model focuses on the trainee, but I think it's a neat component to have that bidirection so that the supervisor is also growing at the same time. Knowing that the interaction between a trainee and a supervisor will develop over time and might be different depending on personality factors or stress levels at the time, or many things that go on in our lives that sometimes we just don't consider, or we're so busy that we forget that those things are important. And in addition to that, we want to make sure that we don't reinvent the wheel, that we use our colleagues for backup and for support, that we have exchange programs. Dr. MacDonald, during her time in New Mexico, took on one of my fellows and did an exchange program where my fellow came to visit and was able to do a pediatric rotation and learn about the Spanish and cross-cultural aspects of Dr. MacDonald's program while she was there. So really focusing on community partnerships and didactics, and using other resources that are available to us so that we feel more supported, and also to be realistic, to cut back on the load because it's a lot to take on. I think here for the BCM program, one of the things that I want to highlight, which really shows that level of collaboration and consultation, is our Taquitos de Sesos program. So I had the opportunity of traveling to Guatemala and to Colombia a couple of years prior to the development of this model. And it was, interesting to hear that a lot of times the students in the States would say, well, I don't know how they do it abroad or internationally because I don't have those contacts. And then when I was abroad, people would say, well, I don't know how they do it in the States because I don't have those contacts. And if you thought about it, we were both lost together and had very similar issues, and nobody could really help us. And if we would just communicate a little bit better, I think we would make gains a little bit faster. And so that's where the Taquitos de Sesos program came about. It was to provide a learning platform, not just for trainees, but even for seasoned clinicians, because a lot of times those folks are also very busy and don't have time to do this extra learning that our field requires, and we want to make sure we're up to date. So Taquitos de Sesos, if you have not heard of this program, I invite you to join us. We meet the fourth Friday of every month from 12 to 1 Central Standard Time. Pardon my cheap plug, but I'm very excited about the program. We have almost 800 participants worldwide. People join sometimes late in the evening or in the middle of the night to be able to hear some of our speakers. And it is through this collaboration of education and training that we have been exposed to a lot of new material and have been able to implement some of these gains into our day-to-day practice.
And as Adriana was sharing, like this education and training could be a whole other presentation or maybe two, depending on what we've been doing. And I think this is an area where both programs have dedicated a lot of time to be mindful and thoughtful of this. And partnerships are very important. So the one that I'll highlight was, we were living through a COVID-19 pandemic, but also a racial justice pandemic in the United States. And this really was amplified in 2020 with George Floyd's death. And it took, the program Inclusive Excellence at Texas Children's was known. We had built a lot of partnerships. And I was getting a text message at 7:15 saying, well, the president of the hospital wants psychology section to put together a plan to really think through how are we going to address this as a section and also as a hospital. So please put together, a plan in 24 hours. So we went to work, and that really, we created a collaborative on racial equity and inclusion for Black youth within our section, and a partnership with human resources. So now some of our, myself included, some of our clinical psychologists are certified trainers on the Franklin Covey unconscious bias training, and we've trained over 1,000 members of leadership at different levels, from managers, administrators, executive leaders, and it's a year-long program. And because we were trained as a psychology section, now we're also bringing it in to train our faculty, and have developed a whole forum program for this year that will start in October, and integrating it. And we were already doing it for students, and that became apparent in one of our quality improvement. We were training our students really well, but our faculty, our leadership really needed more training. So it is really a ripple effect. And in thinking through education, how much impact that can have. And it's not enough to train our learners. We have to train ourselves. We have to train our leadership, and really all of us be on the same page. And it's intentional work that needs to happen. And it really highlights that it's all a collaboration. We wouldn't be here without our partnerships and our leadership roles, our memberships and partnerships with Adriana. National collaborations, that's what brought the model together, right? I was at UNM as, I was the only pediatric bilingual provider in the state. And I was like, I needed to consult. I needed someone to share, like, what was my experience. So really it was through national and international collaborations, as well as institutional partnerships, because as Adriana was sharing, we don't want to duplicate efforts. As we were talking with members of the Baylor community and Texas Children's, a lot of them were doing similar things in silos versus really highlighting and working as a community. So going back to that community theme of, we need to talk to each other to really bring that together. And one aspect of our consultation and collaboration that we share with Adriana is our work in Guatemala. So we're both faculty there. We teach. Adriana took another course this year, so she's teaching 2 courses. I teach one. I supervise practicum students and, their clinical work throughout the year. We've served on dissertations, so really bringing out the work that we're doing nationally and bringing it internationally through partnership.
Sorry, I have too many buttons. The one thing that we want to cover is the development. I think that this component of the model probably came last. As neuropsychologists focused on the healthcare and well-being of others, it's difficult to be a marketing specialist. And I think that this development component really highlights the need for us to consider these things. So looking at this, we're talking about the clinic name, possibly a logo so that people can recognize your space. Looking at the need for an email address that is patient specific in a language that is their native language, where they can feel that it's easily something that they can remember and connect to and maybe understand the meaning of. Looking at websites, I know that TCH is, already making some of these website components available to their staff, but also thinking about social media websites, or even like Facebook pages or Instagram that could be available to patients so that they can receive materials, not just about you in the clinic, but health literacy information that would be available to them. We have to think outside the box and sort of forget our paper and pencil ways, I think, in some sense, especially now when it comes to technology. And the model is really based on a life span process, so that we consider the little ones, our teenagers, and even our older adults who maybe paper and pencil might be more appropriate for them if they're not feeling that they're keeping up with technology. But all of this developmental or development portion of the model, I think, is very important, because if you can't identify the entity, the services that you're providing within your institution, then it becomes harder for you to be able to sell that service when you're looking for partnerships or when you're looking for funding. And so it's really important to be able to have that voice. And I think it also comes, it highlights the importance of having these names or having this entity when you're trying to advocate for patients. So we talked about how the model has its different components, but I think there's also overlay in that sometimes what you do in development can come and be of your benefit when you're looking at patient advocacy. And so, to think of those things and how they might sometimes overlap is not necessarily a bad thing. For the development and action with Baylor, it was difficult to get cerebro at bcm.edu because Baylor had certain stipulations about the number of characters that were needed and the language. And it was a difficult battle, but you didn't want a name that was going to be in English, especially for our monolingual older adults that would have to struggle and figure out spelling or pronunciation. And so pick your battles. Some of these development tasks might not be worth a lot of time, or they might really be something that will put your service on the map. And so think about those things, because it's been an interesting journey with this.
And then for me, I think I've lived the development component through and through in the last 2 years. I've had 3 different titles in the last 3 years since I left UNM. So I came in to Texas Children's to be, the director of cultural neuropsychology. And within a couple months, they're like, well, we need it for more than just neuropsychology, right? This is just a silo. It's a 150-person section with research, autism, clinical practice, pediatric, admin, learners. So we need someone that's going to really wrap around the whole section. So how about co-directing with someone that's been here? And so we formed the Inclusive Excellence program. But, Patty, Dr. Duran and myself are both Latina women who are bilingual. And we have, we don't have any financial disclosures, but we do have our personality and our background as a disclosure, right? Like I serve mostly, my focus has been on cultural and linguistic diversity. And this past year and all of, bringing in to the forefront people that had been doing work, right, in silence or doing these things came to the table. We created a table and people wanted to come to the table and have those voices represented. So we had to switch around, make it a different table and invite more, make room. So now we have the Inclusive Excellence Executive Steering Team. And we actually have 5 different pillars. We have cultural linguistic diversity, racial justice, gender inclusion, disability access, and immigration supports. So it is a big team of 15 leaders. We have training directors, different voices. Today was our inaugural first meeting with student representatives. So we went through a formalized process of inviting fellows to be part of the steering team, as well as a family advocate. So we were talking today about their experience and how we can improve our clinical services. So the table, the size of the table, the voices are truly, a labor of love and being able to hear all of that. So I've had 3 different titles, but it's been a beautiful journey getting here and it'll continue to expand, right? So that's the main important component, where this is a dynamic process. So what it looked like today might not look like in a year. And that's been, it's our 4th presentation, and it's always beautiful to see how we update our goals, how we update our deliverables, and it's a breathing model. And then when we think about, I know we've talked about this a couple of times, but quality improvement, right? We work in a healthcare system where data drives a lot of the decisions. So bringing in this component was really important. At the section, we actually have a quality improvement committee. So they've partnered with different initiatives. I'm part of the committee here at Texas Children's. So we really look at that to not only focus on client services and patient services, but faculty, trainees, administrative staff, and how to improve those processes, that integration, that education. So we'll talk a little bit about those projects.
Yeah, I want to say for us, one of the things that we've learned is that whether folks be English or Spanish speakers, we actually have completed this survey already with our English speakers. A lot of folks don't know what they're coming in for when they're coming in for their neuropsych assessment. And we started off with a survey that asks our patients, should I have studied for this exam? Is it okay that I had breakfast? Are they going to hook me up to a machine or take neuroimaging studies? And it's been interesting to see that regardless of some of the sociodemographic factors that we think would impact this understanding, it really is an issue of health literacy. And given the youth of our field and our specialty, and a lot of folks don't have access to the specialty care, we've learned a lot that we can implement in this quality improvement area. And we're currently still collecting data on our Spanish speakers, running the same survey. With the goal of being able to provide some health literacy information, not only to our patients, but to the referring providers that would prepare them more for their visit and hopefully also give them a little bit of peace of mind so that they know what they're coming in for.
And then for Texas Children's, it was a rude awakening coming here after like what we had practiced at UNM at the Center for Neuropsychological Services, because we would write a report, we would draft a one-page summary and recommendations, and then language services would translate it, and that was just part of our practice. At Texas Children's, I came with the same, was like, oh, let's just translate this. And they're like, no, like we don't have the staff, it's a huge hospital, all these things. It's like, but this is what the faculty really want. We've surveyed them, we did a needs assessment, this keeps coming up. So really thinking through how can we make it a quality improvement project and that it's efficient, that it's in partnership. So we did a needs assessment on recommendations, who was providing them, really got baseline data and highlighted the need for this. All the faculty wanted it, but they couldn't provide the services, right? And we partnered up with language services. We partnered up with our electronic medical record team to think about how can we make this sustainable and something that evolves and build a database of translated recommendations that the faculty are already using and will contribute on a monthly or every 2 months, give us, their top 3 or 5 recommendations. We'll translate them with the language services team and then put them in the electronic record, English, Spanish. They type in a smart phrase or depending on the medical record that the institution has. For us, it's EPIC. And then that'll be it, right? It's in English and Spanish there. And then for us neuropsychologists, it's still right on Word document. We'll have a Word document database that will continue to update, right? So really thinking about the faculty to not make it burdensome or have to learn new technology. Some wanted EPIC, some wanted Word document, and really thinking through, what are the recommendations? How is the system going to be continued to be used? And make it efficient. So that is one of our ongoing projects.
We have the research component as well, and we're thinking that for some sites that might be something that comes later, depending on how you've developed your clinical services and your education and training program. But the model, serves as a reminder for the equitable opportunity in research involvement. And this is not just for our patients, but also for our culturally diverse trainees and our faculty. We know from the research that is available that a lot of times the lack of research for some institutions results in later ability to become promoted in the academic setting because folks are involved in work that might not be counted for promotion, things like DEI work or committees or special training programs. And so we want to use this model to also discuss issues of professional development and how that impacts our field as a whole. For the Baylor team, what we've done is we have collaborated with the STAR Consortium. And while this has been a training opportunity for our fellows and also has increased telehealth services to our patients during the pandemic, because Baylor didn't offer telehealth services prior to that, we're also hoping that we can use some of the data that has been collected to talk about the need for CPT, the need for the continuance of telehealth in our community, and how that allows us to provide services to communities that would otherwise not have access. So bringing in some roles of advocacy and even billing and insurance in order to keep our program alive.
And for Texas Children's, it's really, capitalizing on what Adriana said of promotion and in partnership, because oftentimes, faculty from culturally and linguistically diverse backgrounds, we get consulted, but never are part of research grants or IRBs. So we've actually formalized that process where, our consultation, please include us on your IRBs, please include us on your grants. And this is how we work, and how, include us in publications and in partnerships. So that's been something intentional and part of the conversation where we work with our research arm, and being able to then have the time, because of the research, to develop, for example, our Hablas questionnaire, which is something that I've wanted to do for many years, but didn't have, the research and time to do. So it's a habits, acculturation, bilingualism, language, and academic survey for kids, really looking at that for children and adults, the parents, in research and clinical application. So it's a fruitful partnership in many ways. And the lessons learned are many throughout. We've stumbled. It's difficult work. I went to one of my favorite talks at the beginning of my time here at Texas Children's, and the speaker shared that, if you're doing diversity, equity, and inclusion work and it's rainbows and unicorns, you're doing it wrong, because it is uncomfortable, it is awkward, it is difficult, but it's much needed, and you need to be unapologetic about the work that you're doing. So I am, I often complain with my family, and I'm the one that always brings up these topics. And it's like, well, you're getting paid to do that. So yes, but it is also tiring. And what we've seen in the lessons learned is, the more that you bring it up, the more that you bring in collaboration and bring in those perspectives and those uncomfortable conversations, other people start bringing up the same language. So it's always funny to hear, I'm like, they're using the word inclusion, or they're using the word intentional, and it's not me, and they're bringing it up, and it's not me doing it at each meeting. So it takes time, there's trials, there's fails, there's success for sure. And really advocating for that for funding, for time. So I do have dedicated time for the programming and the work that I do. Of course, it's not enough, but it's been something that, we've advocated for in terms of our administrative leadership, and be able to, even have support to do it from our administrative staff. So things to always keep in mind, and to be vocal and unapologetic about it. Because the journey continues. Absolutely. And we've learned a lot, but there's still so much more work to do. And we continue to use our model as a blueprint. It is solution focused. Sometimes the solutions don't work, and we go back to the drawing board and think about how to really change the system, because the systems have been in place for so many years and decades, right? So it might be a small win, or we need a bigger change, but really we're changing institutional structures and improving our patient services, providing resources for our practitioners, and training and engaging our stakeholders. And that takes time. So sometimes we can't fly, but we can run, and we have to just be patient with ourselves.
So here's just a quick recap of the model now that we've gone through the components separately. We do encourage you to take a look at your current program or your program ideas if you're still working on developing them. This model is not specific to the Spanish community. It can be used across different specialties with different communities, culturally and linguistically diverse. And we're hoping that this encourages you, that it motivates you to look to see what you've accomplished so far, cross those portions out, and then look to see what you have as the next step. And I think taking it one day at a time, sort of one box at a time, I think will be very helpful. And we hope that you will embrace it as much as we do, and that it will be of use to you and your program. So we're running out of time, but quickly for what is next for BCM. Our Echoes logo just came into play last week. So it was neat to have this to be able to share with you. We've tried to incorporate as many of the different languages and the words say culture in about 14 to 15 different languages. And so we're hoping that people will see that they will identify their language, that they will feel a connection with the program, and that they will be able to be serviced here at Baylor. As far as our clinical application and integration, we're working on new health literacy materials for our older adults to address the difference between normal aging and the neurodegenerative process. And one of the things that I'm very excited about is to use now our new connection with the Strutt Consortium to see if there's anything we can do to expand our services in telehealth to folks that do not have the transportation that it needs, that they need to come to the med center, and even the finances, because we are in an area where even parking for an assessment will run you about $12. And then food is pricey as well here at the med center. And so if you can stay at home and still receive the services that you need, that would be an added bonus for our community.
For Texas Children's, a lot of the projects that we've been talking about are ongoing and they'll continue to develop. I think our next one is really working and focusing on our blogs and social media in different languages, starting with Spanish and really curating instead of just translating content. So we'll be working on that this year and seeing our recruitment. I think that is our next step, and the executive steering team is really working on that and partnering with human resources to work on intentional recruitment of faculty and staff for our section. But really the take-home message is that all of these deliverables that we've highlighted are the result of applying the model. We continually assess our organizations. We develop strategic plans and implement them. Sometimes they fail and we go back to the drawing board, but we're implementing structural changes to increase healthcare equity in our communities. It is consistent, intentional, and representative. And you know, it's a to be continued story because there's so much yet to be done.
So we do want to acknowledge all of the folks that supported us as we put this together. We did get feedback. We went to the drawing board several times, realized all the boxes we were missing. We felt like we added boxes all the time, and we're never going to get to the final portion of the model. But we want to thank our colleagues and also our trainees who helped put a lot of these materials together for us so that we can make some progress.
And then there were this slide would have been full of many names that are on the presentation. So I wanted to highlight the names that actually helped with coming up with all the boxes and things, and we're part of the MENTE team, and just the Center for Neuropsychological Services and the Department of Psychiatry and Behavioral Sciences. It was my home for I'm going to say 6 years, and it's motivated the training that I received there, how intentional diversity, equity, and inclusion is integrated in training for internship, fellowship. It's really fueled the work that I do. So I'm so thankful for having and continuing to be part of the UNM family. So thank you. Any questions?
We would love to hear from you if you have any questions. I know we have a few minutes.
I have one question, and one of the boxes that I think when we have these conversations around equity in complicated health systems, in the role of policies, right? So where is it that is something that you give folks opportunities to think through how to do things differently, and what is not an option that the system is saying that this is the way that we feel things should go? And so I don't know, like, if that's a particular thing that you all grapple with this model, and if that's often where we get the most pushback. So
I'm sort of going to indirectly answer this, and I'm sure Tish can chime in, but I think that's why now the focus, Dr. Smart, is on a deliverable. because when we go to the folks here at our institutions, it's hard for us to say, you know, based on this literature or based on our clinical practice, like these are the things that we need. And some of these things, when you look at them, if we really sit back and reflect, some can involve a cost, right? I mean, fellowships are costly, training materials are costly, policy and documentation and all these things that take place in clinic, a lot of times these are not free things. And so it's been difficult, and I think that that's been part of the journey, is trying to figure out what can we do for ourselves, and then where are we limited because it's an issue of the institution, of the structure that doesn't budge or is very difficult to budge. And so now the focus and part of the work that we're doing is taking the portions of this model and submitting some manuscripts. So hopefully in early 2020, you will be hearing from Dr. MacDonald and I and a group of neuropsychologists that we've recruited outside of our institutions, internationally and nationally, to document these issues, and that we can use this as peer-reviewed work to help us with this journey.
But you do point out a very important point, Dr. Smart. I was looking through our elements. I was like, do we have policy in there? And really looking through it, I'm like, ooh, as I said, it's dynamic and continues to grow. I think Kevin, our web person, will kill us if we bring in another element. But I think it is the top deliverable that we can have, right, at a policy level of changing. One of the things in neuropsychology right now is now we're changing the diversity, the Houston guidelines, right? There's a team working on that because nowhere in the guidelines there was language on culture and diversity and equity and inclusion. So it's so important. That's the ultimate deliverable, right, at a national and international level. So I think we're going to have to add some elements to this. So thank you.
Just a comment, Mauricio Tillin here. Thank you for your presentation. I guess what I would say, we should be doing something similar or even better here. Thank you so much. It was wonderful.
Thank you, Dr. Tillin. And you were one of the first ones that we pitched MENTE to, so when we were there. So thank you.
Looks like that might be the last question. Thank you guys again for presenting today, and a lot to think about and a lot that's very relevant to the work across neuropsych and other clinical activities here at UNM. So look forward to the manuscripts.
Thank you. Wish us luck.
Wish us luck. We're almost there. Almost there.
Thank you.